Good morning, good afternoon, or good evening, depending on... Good morning, good afternoon, and good evening, depending on where you are in the world right now. Ladies and gentlemen, dear colleagues, welcome everyone to this digital event, Strategies Towards Improved Patient Outcomes with OTC Analgesics, an event organized by the International Pharmaceutical Federation, FIP. Next slide, please. My name is Lars-Åke Söderlund, and I'm the president of the Community Pharmacy section within the International Pharmaceutical Federation, FIP. I am also the co-chair of the FIP Congress Program Committee for the World Congress of Pharmacy. I have been working during my entire career with the Swedish healthcare sector, as well as with health systems abroad in improving health and creating a sustainable healthcare system. I have also been the president for the Swedish national project Check My Medicines, a project which has significantly improved the therapy for thousands of elderly in Sweden, including therapy with pain medicines. Today, we are going to talk about strategies towards improved patient outcomes with OTC analgesics. And we have a number of expert panelists who will share their experiences and wise comments, as well as give us important updates regarding this very important topic. It is indeed a great honor to moderate this event today. Next slide, please. Before we continue, let us just go through some announcements, some housekeeping rules for today's event. This webinar is recorded and live streamed, and you can also review it later on the FIP events page. The recording will also be available then at our website, www.eventsfip.org. And you may ask questions using the Q&A box provided at the bottom of your screen. And you're also very welcome to provide feedback to webinars at fip.org. And I encourage you to become a member of FIP. So please give us your feedback, as this will make it possible for us to improve future events. Ask questions in the Q&A box at the bottom of your screen. We will answer the questions during the last part of the event. And I honestly advise you to become a member of FIP. It is probably the best investment you can ever make. Next slide, please. And to all of those who are wondering, yes, a certificate of attendance will be sent to all of you after the event. Let us now look at today's program. And we have this welcome and introduction part, and we will discuss personalizing pain management in community practice. We will discuss and get an update and introduction regarding appropriate use of commonly used OTC analgesics in musculoskeletal pain and headaches. And we will learn a lot about stratifying OTCs treatment for osteoarthritis based on individual patient needs. And we will have a panel discussion with our experts at the end of the session. And of course, this will lead to better practices on community pain management, enabling better patient outcomes. And the learning objectives for today's event is that we will get insight and provide community pharmacists with consumer perspectives towards their pain management, and the importance of stratifying treatment based on patient underlying condition and needs. And FIP would like to thank the GSK for sponsoring this event. Thank you so very much for your kind support. Pain is a global issue which can't be ignored. And according to the Global Pain Index 2020, 93% of the participants in the survey suffered from pain during the last year. And 1/3 of the world's population are in pain every day. And this is not just the elderly population. 1 in 5 chronic sufferers are under 30 years old. And whilst pain is universal, 85% of patients could benefit from better relief. Over 60% of sufferers delay treating their pain, lengthening their suffering. And they are looking for specific information and advice, not just products. And as a pharmacist, you can offer them personalized advice for their pain management and help them feel reassured. So pain both acute and chronic, is a significant public health problem that affects so many patients worldwide every day, and of course also creating costs for our healthcare systems. Inadequate the management of pain, and aims to help pharmacy teams to understand how they can improve patient outcomes for optimal community pain management with OTC analgesics. So let's look at today's expert panel. We have Mr. John Bell from Australia, Professor Pamela Kushner from USA, and Dr. Francesco Gammaleri from Italy. Next slide, please. So it is now my great honor to welcome Mr. John Bell from Australia. John Bell is a practitioner and teacher in the Graduate School of Health, University of Technology, Sydney, and has a community pharmacy practice in the eastern suburbs of Sydney. John is former president of the Pharmaceutical Society of Australia and president of the Commonwealth Pharmacists Association and vice president of the International Pharmaceutical Federation. He is currently member of the Global Pain Faculty and of the Global Respiratory Infection Partnership, an international multidisciplinary group established to address the issue of antibiotic resistance. And he is also an advisor to the Pharmaceutical Society of Australia's Pharmacy Self-Care Program, a consumer health information and pharmacist training program. And John was appointed earlier this year as inaugural chair of the Australian Self-Care Alliance. Most welcome, John, to give us your presentation.
Thank you so much, Lars. It's great to be here, and very much my privilege to be one of the speakers, as you said, this morning, this afternoon, this evening, wherever. And you've already mentioned, actually, Lars, some of the issues we're going to talk about, of course. Firstly, these are my disclosures in respect of some of the organisations and companies with whom I've worked. Pain, well, what is it? Just how can we describe it? It's interesting that for the first time in over 40 years now, the International Association for the Study of Pain have updated their definition. It's very similar to what they've always had, except they've added some explanatory notes, I guess, to indicate that it's a biological, it's a psychological and a sociological aspects that bring together how people feel pain. And some of these added notes, I guess, I've put here in italics, that it's very much a personal experience. And what we want to do is personalise our treatment and our management of pain. It's a learned concept. A verbal description of pain is just one way to express pain. It has, as well as an adaptive role, also adverse effects on social and psychological areas. And what we need to do is respect a person's description of pain and how they feel pain. Now, what we will discuss, well, Lars has already mentioned the Global Pain Index. It's a worldwide survey measuring the impact of pain, commissioned some years ago by GSK, and now almost an annual event. And from that survey, we can kind of get a feeling as to who suffers pain, the most people who suffer, what the kind of pain is they suffer, how they currently view their pain management options, what they use to treat pain, and why they sometimes don't treat pain. But more importantly, I guess, how we pharmacists can help. Now, as you know, personalising the management of pain is the overall topic that I'm addressing, but you'll find that Francesco and Pamela will actually expand on what I'm saying and actually get into more personalising of the treatment of specific types of pain. Now, the GPI, the Global Pain Index, well, it was first established in 2014 in these 4 core countries. Then subsequently, a couple of years later, most recently in 2020, so just last year, and we're just getting the results from that now, where we've got those initial 14 countries plus Colombia, France, India, Malaysia and Spain. And as Lars said, a third of the world's population are in pain every day. 93% of the world's population, this is the world as we see it through the Global Pain Index. You'll see the coloured countries there. 93% suffer pain during the year. It's a big number. So what kind of pain do people suffer? Well, they have self-identified 11 types of pain. And you'll see that we can encompass headache, including migraine, tension headache, so head pain, if you like, and then body pain, which includes all kinds of musculoskeletal pain, osteoarthritis, as Pam's going to talk about, but also all kinds of aches and pains, musculoskeletal pain, which Francesco will elucidate as well. Well, what do patients say about their pain management? What they do say, the vast majority, 85%, that they could benefit from better relief. They're not happy with the relief they're getting. The management strategies we're offering them are not satisfying them. 61%, over 60%, say they will discuss their pain with their pharmacist. That's fantastic news. The not so good news is that nearly 50% leave the pharmacy without any clear answer or direction for them to take in managing their pain. So there's a challenge, but a great opportunity for us pharmacists. What kind of pain? Well, we know there's a number of different types of pain: acute pain, chronic pain, nociceptive pain, neuropathic pain, and depending on the type of pain, so we will use different management strategies for the best possible patient outcomes. Headache. What could be the cause? Well, most likely it's tension headache. Less likely migraine or sinusitis, perhaps eye strain. Even less so, as I've put here on this particular slide, it could be cluster headaches, trigeminal neuralgia, medication overuse, which we should not ignore, temporal arteritis. Least likely, thankfully, these things that I've mentioned there in the last point. Well, we know pain is universal. We know so many people, all of us, I'm sure, have suffered pain at some stage or another. But these are some of the interesting issues that come from the Global Pain Index, GPI-4, the one that we studied last year. You can see some of the results there that, interestingly, Gen Z and millennials, they're the kind of 20 to 40-year-olds. That's the area most of us live in, isn't it, that age group? They're most likely to suffer from neck and shoulder pain. I know Francesco is going to talk a little bit about that. Women, less likely to visit a healthcare professional because they think we are less likely to feel empathy for them. They believe we don't take them seriously enough. Is that so? I would hope not, but that's what they think. Women are not all that keen to talk about period pain because they don't think it's well accepted, even though they want to. Interestingly enough, people who delay taking medication suffer longer. That's something we need to address. And interestingly enough too, female parents are more likely to medicate than male parents. I guess you don't have to be a parent to be likely to medicate. Maybe patients, female patients medicate less often. Male patients and parents consult a healthcare professional most often, most likely. Well, we mentioned this at the start. Pain can have a significant impact on people's lives beyond the physical symptoms. We know there's a physiological impact, of course. We know these people, over 60% suffer pain weekly or more often. 3/4 of them say their pain is very severe or quite severe. 55% are in pain for at least several hours. So that's significant physiological impact, but also, very importantly, an emotional impact that we can see here as well. 60% are moody when they're in pain. We also should realise that people who have emotional or mental problems are likely to suffer more pain. So it works both ways. And of course, there's an enormous impact on the quality of life. 83% said their pain has a negative impact on their day-to-day activities. And 72% say their pain decreases with their quality of life. Now, most do take action on pain, but over half the number of people, half the number of respondents to that enormous worldwide survey that we did last year indicate that they delay treatment. And the longer they delay, the less likely they are to take medication, the less likely they are to get reasonably quick relief. So around about 36%, a third, a little bit more, treat immediately. And of those, 73% will take a pain medication, 40% wait a couple of hours, sometimes longer, 16% wait days or weeks. Eventually, these people do medicate, they take medication. Hopefully it's appropriate if they're going to the right pharmacist. That's us, that's you, that's me. But there are around about 10% of people that never take any action at all. They don't treat. Hopefully they get some kind of relief eventually. The majority of late treaters, though, eventually do take pain medication. And you'll see here, these are the reasons why people do delay treatment. Some would rather live with pain if it's not severe. So they reckon they can work through it. They don't want to take pain relief. They'll manage it, they think. Around about 37% try to avoid medication, and 34% worry about dependency, habituation. What do these people do? First of all, they rest, they sleep, they use physical therapy. And of course, rest is not necessarily the best treatment, as I'm sure Francesco and Pamela will tell us later on. 34%, around about a third, only seek relief when they get more information. That is, they go and see us. They visit a healthcare professional. And you'll see down the bottom there, those statistics, the percentage that eventually take a pain medication after the first course of action, which might be nothing to begin with, but ultimately they do medicate. And we are the best people to identify the most appropriate medication for them. Well, how can pharmacists help? This is really the crux of the issue, isn't it? What can we do to improve health outcomes for people suffering pain? We need to ask questions. We need to be inquisitorial. I don't mean to say we put them in a corner of the pharmacy and put that big light on them and grill them, but we need to communicate with them. We need to ask them these kind of questions. Where is your pain? How long have you had it? How severe is it? So something like the 0 to 10, where is it on the pain scale? If 0 is no pain or 10 is really, really painful that you can barely put up with it, or these Wong-Baker faces we can use, often really good for kids. So how severe is it? What have you tried already? We don't want to recommend something that someone's already tried and they find it inappropriate or unhelpful. What health conditions do you have? So are there concomitant comorbidities that we need to be aware of? What other medicines do you take? Not just for pain relief, but what other medicines? And of course, checking for red flags. We need to determine when to refer. If we believe we are not the best healthcare professional to provide the most appropriate treatment, then we need to refer on. To whom do we refer? Maybe the general practitioner. It could be, depending on the type of pain, it could be a physiotherapist, a podiatrist, a dentist. So we need to bear in mind when we need to refer. And there's some red flags here I've identified. I know that Francesco is going to be a little bit more specific with red flags for various conditions, but if the pain is very severe or persistent, if there's neck pain and stiffness with photophobia, for instance, if there's nausea and vomiting or visual disturbance, usually in this case, we need to refer. What to recommend and when to beware? Well, we know, for instance, that opioids are not the most appropriate treatment for mild to moderate pain. These kind of tiles I've got here, if you like, some paving tiles, it's kind of a variation on the WHO pain ladder, but from our point of view, particularly for non-prescription therapies, and that's why I've put the word codeine in there, where it's still available. Codeine in some countries, in other countries, all codeine products are prescription only. But in any event, really for opioids, for mild to moderate pain, the risks outweigh the benefits. And you know the risks there, I've listed them. What about the NSAIDs, the non-steroidal anti-inflammatory medications? We know they're best for short-term treatment only. There are gastrointestinal side effects, and I've listed those. Of course, we need to be very careful if someone has a history of peptic ulcer, but in any event, they can cause nausea, dyspepsia, diarrhea, gastric bleeding and ulceration. There's always the increased risk of cardiovascular events. Now, with some NSAIDs, that risk varies, and that's why I've said there, if we think an NSAID is the best treatment, make sure we choose an appropriate NSAID. Make sure we identify the best dose and duration in the context that short-term is best for NSAIDs. We know that the elderly is more risk of side effects with NSAIDs, and we know they're inappropriate in pregnancy. Generally, they're safe in breastfeeding. This is a recent recommendation from FDA regarding NSAIDs and particularly ibuprofen. So I think we should take note of that as well. But if we need an NSAID, just think about a topical NSAID, because very often they are more appropriate and as effective as an oral NSAID, a systemic NSAID, or an oral. I mean, we do get some systemic effect with a topical NSAID. So bear that in mind. What about paracetamol, acetaminophen? Well, generally, paracetamol is the first choice medication for mild to moderate pain. It's considered safe in pregnancy and breastfeeding. I've mentioned a systematic review, really a systematic review of systematic reviews undertaken by a group from the University of Sydney and published just a month or so ago, Shahid and others, and it was published in the Medical Journal of Australia. They found, despite what we think that maybe paracetamol is not as strong as we'd like it to be, that it is efficacious in acute migraine in adults, in common cold-related headaches or aches and pains, in dental procedures, in in knee and hip osteoarthritis. And I know Pam's going to talk a little bit more about that later. It may be not the first choice, but for many people, it is the only choice. And for episodic tension type headache, there was less conclusive evidence about acute low back pain. We know that it's not really effective for that, or chronic low back pain and rheumatoid arthritis. But nonetheless, paracetamol, acetaminophen, is often the first choice. It generally is the first choice medication for mild to moderate pain. Are there problems? Well, potentially liver toxicity. But at the International Association for the Study of Pain World Congress, just a couple of months ago, there was the consensus that paracetamol up to 4 grams a day is still suitable for episodic acute use by patients with compensated, that's cirrhosis, asymptomatic cirrhosis, including moderate to heavy drinkers. And paracetamol is suitable for patients with chronic kidney disease. If it's advanced kidney failure, then a reduced dose is recommended. Now, what we do need to be aware of with paracetamol, of course, is intentional or more likely accidental overdose by the use of multiple products containing paracetamol. Sometimes it's recommended we pharmacists without prescription. Sometimes it's prescribed by the doctor. Sometimes people purchase paracetamol, acetaminophen at non-pharmacy outlets. So we need to be careful about multiple products containing paracetamol. But otherwise, very safe when taken appropriately, extremely safe. So we need to personalise our pain management plan, but always consider the non-pharmacological options, of which there will be sometimes several. Exercise and weight management, really important, particularly for musculoskeletal pain and osteoarthritis, perhaps physiotherapy, hydrotherapy, cold or heat therapy. Now, in terms of evidence, there is greater evidence for these possible options for non-pharmacological treatment. At the top, the evidence wanes somewhat as we go down that list of non-pharmacological options. So make sure whenever you possibly can, and that should be always, you provide evidence-based recommendations. Thank you.
Thank you so very much, John, for this update on what is pain, who suffers, and from what, and how patients currently view their pain management options and what people use to treat and why they sometimes don't. And of course, how pharmacists can help. And from your presentation, it is clear that we as pharmacists can do a lot more for patients with pain. We will come back to you later with some questions regarding your presentation. And it is now my great honor to welcome our next speaker, Dr. Francesco Carlo Gammaleri from Italy. Dr. Gammaleri graduated in medicine and surgery at the University of Milan in 1991. He finished his specialization in pediatrics at the University of Pavia in 1995 and graduated in pharmacy, University of Milan in 2002. He has worked as a medical doctor from 1991 to 2001 and as a community pharmacist since 2002. He is a lecturer and scientific director of continuing training courses for community pharmacists in pharmacovigilance, and he is also a lecturer of the International Master of Clinical Pharmacy at the University of Milan, as well as in Granada, Spain. He is the scientific co-director of the Community Pharmacist Journal, Tema Farmacia, since 2014, and author of scientific publications relating to pediatrics. And he is also the co-author of the Guide to Pediatrics for the Pharmacist. Welcome, Dr. Gammaleri, to give us your presentation on appropriate use of commonly used OTC analgesics for acute pain.
Thank you. Thank you, Dr. Lars. Hello to everybody. I'm very honored to participate in this webinar. I thank you for this opportunity. I feel very engaging. It's very engaging for me. Here are my disclosure in respect of the organization and all the participants. Thanks. Next slide, please. Okay, here it is my index. The presentation will follow six chapters. First, a general introduction, with general consideration, and we will put some points, general points in musculoskeletal pain and specifically in the management. Then we will underline general alerts in muscle pain. Particularly, I prepare 3 slides in selected red flags conditions of 3 joints, a short overview in headaches and self-medication, and a general conclusion. Thank you. Next slide. So let's start and go in the general consideration in real world. Well, usually patients ask pharmacists regarding pain condition, OTC pain reliever, and the need is surely for rapid action, efficacy, and tolerability. These 3 conditions are perceived different from the pharmacist and also for the patient. General thinking is that systemics are more effective than topicals, but as John has already underlined, is not so true. Of course, systemics are burdened by side effects, and are recommended for surely acute joint and back pain, most in young patients, and of course without gastric and heart problems. While topicals are considered surely more suitable for elderly population who have usually problems with kidney or hepatic problems. Pharmacists can do an important screen at the counter of the pharmacy and should make a choice based on the nature of pain with underlined questions by John, and should check the right profile of the patient. Although great majority of pharmacists declare that recognize a can manage general inflammation condition and pain, there are also interested in receiving up-to-date indication, guidelines, flow charts on self-medication pain to care their patients, families, and of course promote their diagnostics orientation. Next slide, please. Let's see into deep musculoskeletal acute pain. You can see on the right side of the slide a simple flow chart that put in co-positioning topical diclofenac and paracetamol. Usually patients and often most of colleagues think about topical solution as more effective than systemic solution. But the guidelines, recent and systematic reviews show that and demonstrate that topical diclofenac is really a first-line treatment with an effective goal and treatment for many conditions in muscular pain, sprains, strains, of course, sports events related in injuries in young patient with, as underlined before, minimal reported adverse events. Topical diclofenac is really effective and well tolerated in also the treatment of acute neck pain, and can help and improve neck function. There is insufficient evidence regarding the comparative effectiveness of paracetamol and ibuprofen alone. And we can think that we can use topical first or combined with systemic paracetamol, which is, of course, useful in patients with old age. Next slide, please. About topical solution, I want to underline with multicenter randomized placebo-controlled pharmacokinetic study. The literature is signed below the slide, as recently showed in 2020 that diclofenac for topical use remains in joint tissue over 12 hours. So it can explain us the benefit of a prolonged pharmacological effect. And this is another strong reason because topical solution has been proposed and underlined in recent guidelines as first solution. Of course, diclofenac is the referent NSAID and the first choice in acute forms, less indicated in chronic pain, and it can be useful in exacerbation forms to limit chronic pain that can develop later on. regarding the Osteoarthritis Research Society International Guidelines, topical NSAIDs are useful and indicated for acute and localized inflammation, first form of acute pain, and rational use even in exacerbation. And systemic NSAIDs with general pain condition and general illness, fever, and generalized inflammation with intense and high condition of pain. Next, please. Let's see let's in musculoskeletal pain management. This slide can be an integration of John's slide with the title, How Can Community Pharmacists Can Help Patients through the check of this condition with proper and particular questions. We can manage helpfully patient, help families, and empower even caregivers. I want to underline in this slide, particularly the point number 4, and we can read comorbidities, polypharmacy, allergies, and previous adverse drug reactions. We don't have to think to a drug reaction regarding drugs or medicine that need doctor's recipe or prescription, but we have also to think and check the patient if he had previously suffered drug reaction from OTC or without prescription medicine or advices. And we have surely to remember this point because it's very important for the patient and for our advices. Next, please. Then let's see particular red flags for three joints. Shoulders first. Of course, community pharmacy is not a medical office. It's not an ambulatory. So with our communication, our attention, our empathy with the patient, with family, and through the question showed by John, we can also check some critical condition and do our proper work and the right screening of the situation. So we can think about this dislocation with recent trauma, an alteration of the profile of the joint, and a loss of rotation. Again, with recent trauma, acute onset of functional impotence, and drop arm, we can think about an acute injury to rotator cuff. Obviously, this is a specialist condition. Then radiated pain in hand, paresthesial, digital strength, or sensitivity deficit. We can think about neurogenic pain not involved with shoulder. We can think about cervicobrachialgia. Infection condition can show skin erythema, edema, and swelling, fever in the general condition. Most attention, most care with left shoulder pain that increases with activity and associated or described by the patient with sense of chest tightness. In Italy from 2010 and in many other countries, it is possible to have telemedicine reports, electrocardiogram with remote control and remote reporting. So in real time, we can help a patient in suspected critical condition. Then point 6, asthenia, loss of appetite, weight loss, swellings, and oncological history can can let us think to tumor pathology. Next, please. Elbows red flag. Joint problem, of course, in joint limitation. Again, cervicobrachialgia, if paresthesia is spread to the whole limb. Arthritis, Pamela will tell us more about it, with skin erythema, concomitant presence of pain and swelling elsewhere. Again, tumor pathology with general asthenia, weight of loss, fever, and oncology history. Next, please. Last one, particularly red flag for ankle. We can think ligament injury or fracture with a noise referred by the patient at the time of trauma. The rapid onset of very intense pain and swelling and progressively an hematoma can let us think to ligament injury, hemarthrosis, and in progression, fracture. Arthritis, again, with skin erythema, concomitant presence of pain and swelling elsewhere. If we have to manage advanced people in age, advanced patient, syncopal episode and risk of falling can conduce or fracture and ankles problem. On the right of the slide, in the bottom part, I have signed the 4 important points used by specialists in emergency department or GPs to identify conditions that need X-ray examinations. Of course, as I said, pharmacy is not a medical office, but the 4th one is very able to check even in pharmacy. And we can use it every day during our work and see if the patient has an ability to walk at least 4 steps. It's a critical condition that needs probably an X-ray examination decided, of course, by specialists and GPs. Next one. This slide shows a short overview regarding headache, in particular tension type headache and migraine, in 2 columns. I've divided the condition in 2 situations: symptoms and associated symptoms. Symptoms for each condition have to be present at the same time, at least 2 conditions, and you can see the situation. It's very important to know that bilateral pain is very often associated to tension type headache. Instead, unilateral pain is characteristic for migraine condition. About associated symptoms in the below part of each column, the presence or the absence of nausea or vomiting can help us to choose the condition. Even the photophobia or phonophobia is another condition to check and ask for the patient. Photophobia and vomiting is more characteristic of migraine. The 3rd column on the right of the slide show symptoms that require immediate medical check. We read together fastly because timing is running fastly again. pain always localized in the same point. It's an important red flag described by the patient. Even headache, rapid onset after 50 years of age, sudden onset is critical, and high frequency of painful crises and progressive painful crises. Profuse and persistent vomiting can let us think to recent trauma, tumor condition, even orthostatic headache is a red flag condition, and even headache following physical activity. Next one, please. General management in adults and children. We can see that paracetamol has a co-positioning with ibuprofen. First line in population that have gastrointestinal risks, bleeding, ulcer, of course, cardiovascular disease, and elderly patient with kidney or hepatic impairment. Ibuprofen is a first-line choice among NSAIDs in young patient and in children. I want to put out that in Italy, ibuprofen had been deregulated in prescription since 2009. So we have to take care with mommy and with caregivers, because they have a great facility to give ibuprofen to young patient, to children, for his efficacy. In hard and medium condition of pain, paracetamol and ibuprofen is combined with caffeine, and of course is cited in the guidelines, and the efficacy is higher in combination. German and Italian guidelines recommends paracetamol and caffeine as first level and as first line, but ibuprofen and caffeine is recommended in Italian guidelines only. Next one, please. So let's see the first slide. I've checked and used this title about regarding the everyday challenge in community pharmacy, using turn pain into gain. I checked it participating a few months ago in an international advisory board, and I listened to Dr. Joyce McSwan, which is who is the president-elect of the Australian Pain Society, a very, very brilliant colleague. And I liked it so much, so I checked it. As John, in the last slides of his presentation, has showed us, possibly the pharmacist has to make a holistic vision, and he has the possibility to check all the problems with good question, good communication, and his capacity of empathy. Easy to say, not so easy to do. Of course, this pandemic condition make everything more complicated. Patient and practitioner are always in a hurry. It's not so easy. It's not so easy to put the good question, the right question, in the good mood, but we have to challenge, and we have to try it every day for with each single patient, with the families, and of course with the caregivers. This way of proceeding for all of us community pharmacists can help us to walk a new path with the changing from evidence-based medicine challenged by clinician into pharmacy or pharmaceutical-based medicine with advices and validated recommendation. I wanted to underline, as John has done before, to be alert to maximum daily doses and the potential over medicating with multiple products. And doing this, we do the proper empowerment of patient and caregivers with integration of skills of all healthcare practitioner. We can surely have a patient-centric care goal. Thank you. Next one. This is my last slide on my presentation. Of course, we need alliances between healthcare practitioner and patients. I point out these 4 conditions, but underline in particularly the last 2, adherence and persistence. Adherence indicates the degree of actual coincidence between individual behavior and therapeutic indication of community pharmacy, which is required to provide a clear and precise instruction on the use of drugs. This is very important because on this path, we reach a conscious role on the treatment of the patient. Of course, persistence is equally important because the continuation of a therapy for as long as necessary for the completion of the cure treatment is necessary for the home care treatment and help surely the patient. Thank you for your attention and thank you for the opportunity to stay with all of you. Thank you again.
Thank you so very much, Dr. Gamalieri, for your excellent presentation on general considerations on pain, acute and chronic musculoskeletal pain, and general alerts, red flags in joint pain, and of course, self-medication for headache, and also about the everyday challenge, as you mentioned, turning pain into gain, and not to forget the alliance between healthcare professionals and the patient. This is a key issue as well for good therapeutic outcomes. Next slide, please. It is now my honor to welcome our next speaker, Professor Pamela Kushner. Professor Kushner is a board-certified family medicine doctor at the Kushner Wellness Center in Los Alamitos, California, USA. She is a clinical professor at the Department of Family Medicine at the University of California, Irvine Medical Center. And she received her medical degree from the School of Medicine at the University of California, Irvine Medical Center, and completed a residency in family medicine at Long Beach Memorial Medical Center. As the first woman president of the Long Beach Medical Association, Dr. Kushner chaired the American Academy of Family Physicians, Women's Health Continuing Medical Education, and the Committee for Drug and Devices. She served as the association's representative to the U.S. Food and Drug Administration MedWatch for 15 years. And as a California Medical Board reviewer, she has been highly active in educating other family physicians about the newest medical therapies. Dr. Kushner's practice specializes in medical care for the entire patient. She has managed an osteoporosis diagnostic center for over 12 years, and she is trained in complementary medicine and is a certified lifestyle educator teaching patients healthy nutritional habits. Her areas of clinical research include arthritis, asthma, diabetes, erectile dysfunction, hyperlipidemia, hypertension, depression, and osteoporosis. And she is a past recipient of the American Lung Association Smoking Cessation Award and Soroptimist International Women of the Year, in addition to receiving the Best Teacher Award from the residents at the University of California Irvine Medical Center in 2015. Dr. Kushner has authored or co-authored articles published in peer-reviewed journals such as the Journal of Family Practice, Journal of the American Board of Family Medicine, Journal of Bone and Mineral Research, Postgraduate Medicine, and Stroke. And she is on the editorial board of the Clinical Diabetes Program. Welcome, Professor Kushner, to give us your presentation about stratifying OTC treatments for osteoarthritis based on individual patient needs.
Thank you very much, Lars, and thank you to the esteemed speakers who spoke before me. I'm very honored to be here today. These are my disclosures that are relevant. And I'd like to start with is, what is the role of the pharmacist in 2021, and what can you anticipate in the future? So this is information related to the United States Bureau of Labor Statistics. And what they have come up with for 2021 is that clearly the roles of pharmacists are evolving. You will probably not be in the same job now that you're in now in 7 years. And what they see happening is that you will be, as pharmacists, doing more consultations virtually and have more of a digital connection with patients, as we all have learned to do more telemedicine in the time of this pandemic. You will be having more consults online, in addition on the phone. So right now we have many pharmacists that are involved in independent drugstores and chains, and the role of the pharmacist has become increasingly recognized and expanding. I see this as vital. I see pharmacists as critical members of the healthcare team, and I'm glad to see the increased appreciation that is happening and the increased acknowledgement of the level of education that is required for pharmacists. We need a team. We need a village. We've talked about chronic pain, and I love the presentations that were before mine. But when we think about chronic pain, what we need to recognize is there's a lot of noise going on in the nervous system. And the longer patients don't get treatment for chronic pain, which was well described by John, the higher risk they have to having more permanent pain from this increased noise. So pharmacists are going to need more clinical expertise. So remember that presentation that you just heard from Francisco. You're going to have superior skills at counseling patients, and I hope to leave some time to go through some of the ways you can do this. And yeah, you'll have to know about reimbursement and insurance systems, but you'll know more at a practical level as to some of the ways patients can use their healthcare dollars more effectively. Next slide, please. So what do I expect as a primary care clinician from a pharmacist? Well, my expectations are that we do work together as a team. So I want the pharmacists, the community pharmacists, to help my patient understand what the over-the-counter options are for them. I want to make sure that they fight against polypharmacy, as Lars has. And so that what we do in the United States is we call a brown bag technique. Patients are urged to bring in their brown bag of what they take regularly. So I can see medications that may be considered herbs and harmless, but may interact with other medications that they're taking. And the health literacy throughout the world is at horrifically elevated levels. And anything that we can do as members of the healthcare team to educate patients about their healthcare needs and about their conditions is going to be valuable in the long term to achieve what Francisco said about the persistence in taking medications appropriately. In the United States, we don't use the term compliance anymore. We use the term adherence. And the reason we use the term adherence is because compliance indicates that the patient is compliant to what you've chosen for them. But no, the patient needs to have shared decision-making in what the right choice is for them. So if we can have a patient understand the risk and benefits of the over-the-counter treatments and other modalities that are available in your local pharmacy that they have not tried yet, this is going to limit drug interactions, and it's going to make for a more effective treatment plan. I also want to make sure that warning signs that may be picked up in the pharmacy are reported to me as a clinician so that I could address them at the next meeting. Now, the issue is, why are people going to pharmacists more? Access. You're more available. You're more familiar. It's part of the community. The word community pharmacist has tremendous meaning. And the frequency that I see a patient and the availability of my time to sit with that patient when I'm addressing all of the needs of that patient as a holistic family physician is limited. Not that your time is not limited, but you are more accessible. So a very valuable member of the healthcare team. Next slide, please. So what are my goals in osteoarthritis management? Well, I want to make sure that the patient understands the risk-benefit analysis of the medications you're taking. I want them to have realistic expectations. A patient who doesn't move may have less pain, but I want to know how much they move on a daily level, because no pain, no gain. The value of exercise cannot be overstated in this presentation. Treatment expectations and realistic expectations can be infiltrated into the patient so that they understand that even a minute of exercise twice a day, getting up every half hour, make sure you're doing it too, so that we sit in front of computers for such a long period of time, not thinking about how that strain is for our lower back and for our neck and other joints. So establishing treatment goals is not just my job, it's your job too. Encouraging collaborative care. Next slide, please. What do you do to diagnose osteoarthritis? Over age 50, joint pain without a trauma, joint space narrowing that may have been shown on an X-ray. Next slide. All of these can be indicative. As you've already spent some time on arthritis red flags, I'm going to add a few more to Francisco's extensive list. Psoriatic lesions. You can look at somebody's nails and see how healthy they are. Are they talking to you about skin lesions in addition to arthritis pain? Do they have a symmetric polyarthritis tender joints that has gone on for more than 6 weeks? Do they say it's hard to get out of bed until 30 minutes have passed? Have they had a history of trauma? Do they have a swollen joint that is not going to be able to be repaired in the pharmacy and locally, especially if it has an effusion, because that effusion may need to have a fluid analysis? Persistent pain that has gone on for at least 10 days and has an abnormal intensity should be seen by a clinician in the office. Next slide. These are a list of some of the polyarticular pain causes. I just wanted to highlight that if a patient has a rash on their face, of course, you want to be thinking a little bit about lupus. If the patient is having a depression, you may want them to be going because there are medications that can be working for pain orally in addition to help manage their depression. Next slide. I don't want to underestimate the role of supportive equipment. There's so much valuable supportive equipment at your fingertips in the pharmacy. A patient may say, gosh, doc, I love going to work, but having to walk up those stairs really hurts my back. They may benefit from a cane just to go up the stairs. They don't need to necessarily see a physical therapist for that. Stable supportive shoes should be supportive. Sometimes little advice like having shoe inserts, particularly for people who have knee arthritis. The value of gels in the back of that knee, the back of that shoe has tremendous value. Daily living. Make sure that you get the information from your patient as to what is their activity of daily living. Who is their support system? Who do they rely on? You're the pharmacist, you're the member of the community. You want to know who their support system is. Are they able to make their own food? Are they at danger? Are they locking themselves out of their homes? Also, making sure that maybe using a brace is often very useful for knee arthritis. Social support is valuable. Now, in the day and age of the internet, many people say, well, I could just go to an online Facebook support group. But we are human beings. We require personal contact. That's why we use the word healing touch. We want to address modifiable risk factors. That's why we say this is shared decision making. If a patient loses 10% of their body weight, they have a 50% reduction in pain that is in joints that are being overly burdened in 18 months. That's a good statistic to remember. 10% body loss can help bone comorbidities and help that patient have a decrease in their pain. Joint alignment can be helped by braces, splints for osteoarthritis of the thumb, for example. We want to limit further joint damage. Next slide. If you have persistent osteoarthritis symptoms that are not able to be treated with what you have at your fingertips in the pharmacy, and ideally with a topical medication, because that is less absorption, so less side effects overall, then the patient may be requiring something like oral duloxetine, which was not mentioned. Even pain medicines like tramadol, we're trying to having less involvement with tramadol, opiates, and gabapentin. But in some cases, particularly for neuropathic pain, they're very valuable. If a patient says to you, I'm getting intra-articular glucocorticoid in steroids, that could be very valuable. However, remember, this is for short-term relief. And if a patient says they've had 3 of those injections, the data stops there. The osteoarthritis injections with glucocorticoids really does not have a tremendous amount of data beyond the 3 injections. If you see a patient is continuing to have symptoms that they're not able to manage their pain, they may value from cognitive behavioral therapy, which is now available online, or to go to a cognitive behavioral therapist. I can't tell you enough how the value of the mind-body connection is so important. And yes, things like yoga, Tai Chi, very valuable, meditation, but also cognitive behavioral therapy, even breathing exercises that can help your patient rest more comfortably at night. Next slide, please. That multidisciplinary team is critical. In the interest of time, I will go quickly through this slide, but notice that you're on here. Family support, primary care physician, pharmacists, and then of course, referrals to physical medicine and rehabilitation, occupational therapists, rheumatologists, and orthopedic surgeons as necessary. Next slide. So when do I want a phone call? If you see something worrisome, a worrisome risk factor, this patient is not doing their activities of daily living. They're having polypharmacy, maybe even from my office, even though I try to do medicine reconciliation. If they are having an increase in pain, progressive symptoms, please urge them to contact me. I want you to report any potential drug interactions. Discuss with me alternative choices. Any adverse treatment related to their condition that you see is from a medication, or that they're supplementing their medication with something that I'm giving them as well, something that they're getting over the counter. So all of these, I think, are very appropriate interactions that increase the value of multidisciplinary care. Next slide. Oral nonsteroidals are only recommended when inadequate relief from topicals topicals have been maximized. I'll go through a little bit of the guidelines with you. If a patient has hip arthritis or multiple joints, yeah, they're going to need an oral nonsteroidal, maybe in combination with acetaminophen. But always remember, lowest dose as possible. Something that was not mentioned earlier as a comorbidity risk, as a precaution for oral nonsteroidals, is renal disease. Chronic kidney disease is often not diagnosed or treated appropriately in the early phases when it's asymptomatic. Acetaminophen, used widely, no longer first line based on guideline recommendations. And somebody asked in the question and answer, liver precautions, yes, a patient can use it. You do not want to go over 3 grams a day if they are having a liver problem or if they're drinking a lot of alcohol. The other issue to remember is I've had many calls, can I take 3 Tylenol, 3 acetaminophen at once? No, you can't. You can't take more than 2. Next slide, please. in the interest of time, I will just summarize this slide for you. Somebody asked, what about local hot or cold? Well, it's going to depend on your condition. If you went on a run, if you took a long walk, cold would be more valuable before and after. If a patient is having a swelling in a joint, heat is more valuable. Oftentimes, even something that warms your hands that you can stick your women use to get their hands ready for a manicure is very valuable for osteoarthritis of the hand. Balneal therapy, a hydrotherapy, very valuable if the patient is in at least 20 degrees centigrade. Kinesiotaping, I did not mention earlier, you have that in your pharmacy, really good for foot pain, very good. That's where you use these tapes. Acupuncture has some data about it. If you are going to use acetaminophen or paracetamol, you want to use it in combination with a non-steroidal topical or oral as necessary for pain. In terms of nutritional supplementation, you would want curcumin to work. It looks on paper that it's going to be great, but realistically, it has no data supporting it from, there was a recent medical review that was conducted last year, reported in Nature. There just is not data to support it. There is more data to support boswellia, particularly in a oil form. Glucosamine and chondroitin, I don't stop patients who take this. They're relatively harmless, but their data is really only for 1,500 milligrams of glucosamine or chondroitin 800 milligram, mostly based on the GATE study, which it had 60% of the patients had a 20% improvement in pain, and that included the placebo group. So this is not a good data-driven medication combination. Next slide. To summarize, this is going to give you some of the data that was done, a study by GSK, which was interesting, that talked about how can we combine paracetamol with topical nonsteroidals. There is significant evidence. Many clinicians are not aware of this evidence. So we want to make clinicians more aware of that combination that may be very effective. Next slide. There are many guidelines on all of these things that you can go to in the references that support what I'm going to show you next. Next slide. So here we go. Concentrate on the light green. Diclofenac has a strong body of evidence topically, followed by ketoprofen and ibuprofen. The question was asked, what about ketoprofen, patch versus the gel? It really depends on patients' preference. They're both fine. Compared to diclofenac, they have much less data. Now, when we look at the rubefacents, do you know what that means? That means turning skin red. They can be irritants. There is data behind capsaicin. If your patient can tolerate it, it has to be put on frequently, but there is some data for it, particularly for hand arthritis. In terms of the other salicylates and menthols, they smell good. There is a value to smelling menthol. There is a value to smelling eucalyptus. But in terms of having good evidence behind them, there really is no good evidence in using these products for arthritis. You see listed below other, that even includes clonidine. So a lidocaine patch has excellent evidence behind it. Next slide. Topical nonsteroidals for mild to moderate arthritis of the hand, knee, foot, and ankle. You see the checks over here. There's many guidelines from NICE, OARCSI, the European EU LAR, all of which say that diclofenac, ketoprofen, ibuprofen, capsaicin gel, and lidocaine have been shown to be effective. You can see the little X next to the rubefacents with salicylates. Next slide. American College of Rheumatology has guidelines. Again, the dark green is best. The light green is second best. They say strong recommendation against bisphosphonates, glucosamine, and methotrexate, and some of the other ones that are listed here, so that this is a very valuable resource, I believe. Fish oil, vitamin D, no, these are conditionally recommended against. There's just no data that supports them. Next slide. What about soft tissue injuries? Again, you see the same recommendations, except here you see that There is some limited evidence supporting use of rubefactants for soft tissue injuries like sprains, strains, bruises, tendinitis, and bursitis, with the evidence of capsaicin for musculoskeletal pain pretty trivial. So I would not recommend that, particularly for musculoskeletal pain. Next slide. Topical nonsteroidals for back and neck pain, capsaicin, topical diclofenac, very valuable. But if you want to think about the salicylate products for acute injuries and the chronic pain, really make sure your patients are not using inappropriate medications chronically that are preventing them from using more effective therapies. There are many good adjunctive therapies available. Next slide. So in summary, there are oral and topical nonsteroidals. Clearly, you want to choose topicals before you use orals. It's okay to combine nonsteroidals with acetaminophen. The clinical guidelines say that topical nonsteroidals should be used as a first line of treatment on for pain indications. Diclofenac gel, solution patch, plaster with or without epolamine or DEHP are most widely studied. There's just not the data supporting rubefactants. And capsaicin has the most evidence that supports it as an adjunctive therapy. I'm now going to turn this back over to the very capable hands of Lars. Thank you for your attention.
Thank you so very much, Professor Kushner, for discussing the role of the pharmacist in pain in 2021 and the evolving role of the pharmacist and what to expect from a pharmacist today and tomorrow. And of course, also the value of teamwork for the patient, true collaboration, health literacy, and from compliance to adherence, and the different treatments options, as well as the holistic perspective on pain and treatment. Very, very important to remember the words adherence and teamwork, of course. Now we would like to ask our experts to turn on their cameras to be part of the panel discussion. We have many questions for you. And first of all, I would like to ask actually Dr. Gammaleri, is there a comprehensive approach to like a single patient journey when it comes to pain and symptom-based treatment approaches?
Well, it should be this one the way, but it's not easy to do, especially in this period. We need time. We need space in pharmacy. We need quiet. We have to try it anyway. I mean, I feel and I see in my experience that there is an asymmetric condition between the possibility to reach the medical doctor and an easily way to reach pharmacy. So sometimes families and patients are not able to reach the GPs. So and even in a mild condition and in a difficult condition, arrive first in pharmacy. So the pharmacy should be able to make a screening and help to divide the condition if it can be managed in home care management, or drive the patient to the doctor or to the specialist. Thinking that it's not easy to reach hospitals in this pandemic situation.
Thank you so very much. And linked to this, we have a question from our participants, and I will direct that question to Professor Kushner. As Dr. Gammaleri said, screening guidelines and protocols, is that a way of sort of assuring that the patient is treated and referred effectively to the physician if it's necessary. Because the question is there a risk that when pharmacy is the first sort of stop when it comes to patient engagement and discussing the symptoms, they can actually, a treatment from an OTC can mask the underlying causes and may delay early diagnosis of another disease. What is your perspective on this?
So I have two answers to that. The first one is, don't worry about that, because of the fact that if you have when a patient comes to you, if they're having persistent pain that's gone on for 10 days, 10 weeks, well, then that's a patient that, yeah, they should be seeing somebody if they've tried over-the-counter medications first. But otherwise, the clinician is going to often say, have you tried over-the-counter medications for this? Who do you have to worry about? The red flags that Francisco gave you and the red flags that I gave you are very important. If a patient has rash on their body, if the patient says that the pain is getting increasingly worse, it's keeping them up at night and they've tried over-the-counter medications, if the patient says they can't get out of bed for 30 minutes in the morning, that could be a sign of rheumatoid arthritis that should be addressed. But otherwise, there is no harm to giving assistant aids to patients for them to use topical therapies as well, because that may prevent an overdiagnosis of their condition. The other point that somebody did ask, if you don't mind, Lars, somebody asked in the question and answer, was there data about cannabinoids? In fact, I literally just went to a medical education lecture myself yesterday on cannabinoids from the head of UCLA. And they've studied it extensively for topical arthritis, and orally there is no evidence that supports it, other than it has an analgesic effect in terms of as an anxiolytic, that it may help anxiety that is associated with pain, help insomnia in the sense that it makes people feel sleepy. Acetaminophen does that as well. So hopefully that helped answer the question.
Thank you so very much. And this is a question for all our participants, for all our experts, and please give me a short answer if you can. How do we counsel the patients in a digital world? Because the pandemic has actually accelerated the digital development of care in so many different perspectives. So how do we actually make sure that we really understand a patient or a consumer online, or even if in a telephone call? How do we show empathy and like person-centered care? Would you like to start, John?
Yeah, thanks, Lars. Look, I think in a way, the pandemic has given us enormous opportunity as pharmacists in Australia, for instance. The general practitioners were doing mostly telemedicines, but pharmacists were all open and people were coming in to us in the first instance. Now, of course, in some ways, we've been talking in telemedicine as well, or telepharmacy, I guess. It's a matter of taking time. That's not always easy when you've got a business, a busy practice to run as well. But it's important that we treat people telephonically the same way we would treat them in the pharmacy. And that is with empathy, with sympathy, with assessing the same type of way as we would if they were there in front of us. But what I think it's done is enable the pharmacist to be more prevalent, to be in the forefront of a whole range of therapeutic management, whether it's pain or anything else. So I think it's been a very effective enabler for us.
Thank you, John. Pamela?
So I'm going to try to give you really quick pointers. You know what this means. This means I feel your pain. This can be done verbally. This can be without a word. I feel your pain. When you're talking from telemedicine, lean forward. Make more exaggerated expressions, because that's received better. When you are seeing somebody in the pharmacy, in order to be effective in a very short length of time, you want to be able to listen and stop yourself from interrupting. It gives you more presence, even if you have very limited time. So tell me, what brings you in today? Who is your major support system? What have you tried before? Open-ended questions. And finally, there is something to be said for your body language being receptive, open, and encouraging people that I'm here for you. Those type of open-ended, supportive empathy is critical, but how you express it, remember, there's many ways that you can do this in a short period of time. There's something to be said for the healing touch. People like to be touched. That you can't do online, but you can symbolize it online.
Thank you. Thank you so very much. Francesco?
Well, I would say that first, we have to let the patient, let the people talk, and be ourselves in condition to listen and to look the light of the eyes of the person in the screen, or physically in front of the counter in pharmacy. This is very important. Listen and take a short time, and then ask why you are here today and not yesterday. What is changing? What did happen tonight, this morning? And another funny things about real life condition, during the period of lockdown, people came in pharmacy not even to for medical advices, just to talk, because there were anybody out there, only police forces, and they couldn't go anywhere. And to see the pharmacist and the laugh and the eyes of the pharmacist sometimes was a kind of light but nice medicine.
Yes, thank you so very much.
Francisco.
Thank you so very much, all of you, for very wise and good answers. I have one final question as time is running out, and I will direct that question to John. How to know when to use hot therapy and when to use cold therapy for pain?
Well, I think Pam covered this to some extent, Lars, and that is for an acute injury, generally it's cold therapy. For a chronic injury, it's probably more likely to be heat therapy. But if it's for a sports injury, for instance, if it's someone who's suffered a soft tissue injury as a result of sport or running or whatever it happens to be, then the initial therapy would be cold, possibly along with paracetamol, or for a younger person with no comorbidities, an oral NSAID. But for maybe ongoing treatment of osteoarthritis, as Pam mentioned, for joint pain, then heat therapy would be more appropriate.
Thank you so very much.
Don't forget moist heat. Moist heat is very valuable.
Thank you. Thank you so very much. Can we have the next slide, please? So we would also like you all to participate in a short survey to find out what kind of support you need in your practice to optimize the outcomes of treatment or for counseling your patients. So in your screen, you will find a number of different options to choose from, and you can choose the ones you think are relevant for you. And this means you can tick more than one choice or option, or all of them if you want to. So please try to do this survey now, because this will also give us an understanding how we can continue to support you, and which furthermore will lead to improved value, both regarding treatment as well as meeting with the patient or the consumer. So choose the options you find are relevant for you. Mila, do we have a result or? I think shortly it will appear on the screen how you voted in this poll.
Lars, I'm already sharing the results. Can you see them?
No, I can't see the results. No, no, I can't see them.
Can I ask Rachel, for example, can you see the results?
Yeah, they've just come up. So the main one was 56% for patient counselling skills.
And next?
The next was the pain diagnostic tools at 46%.
So, and what regarding the other options?
We've got the regular updates on consumer behaviour towards the pain management, simplified product information on appropriate use of OTCs, and then the lowest one was patient support materials at 33%.
So in the first case, patient counseling skills as well as patient diagnostic tools are very important as we perceive it per today to develop our options to treat and counsel the patients. Can we have the next slide, please? Well, we have had the questions, and thank you all of you for participating in the poll. That will give us an indication for how we can develop these kind of events for the future when it comes to pain. I would like to thank our distinguished panelists for sharing their experiences as well as providing us with very wise recommendations regarding strategies toward improved patient outcomes with OTC analgesics. Chronic pain has for years been poorly understood and poorly treated, that is for sure. And more patients and healthcare providers, as the experts we have with us today, are recognizing chronic pain and acute pain. And this should reverse this trend and improve the lives of patients around the world. And where pharmacy, as the most accessible healthcare provider in collaboration with other healthcare providers, has a key role. And when it comes to communication, having a dialogue with the consumer or the patient. In today's world of hybrid working and digital communication, we are all immigrants and learning a new culture and language. And of course, the learning curves are inevitable, but whether we like it or not, being a good healthcare professional or a team colleague means that we need to actually master this type of body language that actually didn't exist perhaps 20 years ago, and that one that continues to evolve at a very rapid pace. As mentioned, pharmacists are, as other healthcare providers, key actors in pain management. And of course, as we counsel the patients and also try to support patients with other medical treatments, it's important that we actually have the communication skills as well as the competence to perform, for example, discharge counseling or post-discharge follow-up and planning. And of course, it's all about the collaboration with other healthcare professionals and with the patient. And I think it's essential for the profession to provide standards and perhaps protocols to support pharmacists and of course backed up by the best evidence in order to increase confidence and maintain credibility among patients. And having access to the right information and having the right skills gives confidence to pharmacists and their entire teams and to the public, of course. So once again, thank you so very much to our all expert panelists for sharing your experience and providing such valuable insight to our discussion today. And next slide, please. I would like to invite you to join me in celebrating the World Pharmacist Day on September 25. Pharmacy, always trusted for your health, is the theme of the World Pharmacist Day on September 25. Evidence indicates a significant association between trust in healthcare professionals and health outcomes for patients. And this is especially true linked to today's event. We have heard so many examples of this important connection. So I invite you all to join us around the world to celebrate the World Pharmacist Day on September 25. So by this, I would like to thank all of you once again for a fantastic session, a fantastic digital event. We have learned so much. And for me as well, it's, I think for all of the other participants, it is clear that we need to learn a lot more in order to become the best choice for our patients when guiding them with pain. So this has been a most important and a most valuable session. So thank you all so very, very much. And by this, I would like to wish you a very nice afternoon. Thank you so very much.
Thank you. Be well.
Bye-bye.
Bye.
Bye-bye. Hello.
Bye.
Bye. Thank you.